Okay.
What is the median DFS, disease-free survival?
Okay.
R0, as in all the margins are clear.
Negative. Yes, sir.
Give me a number. How many months?
Maybe 24 to 30 months.
Okay. Raghu, what is your number? Median DFS.
Medium disease-free survival.
Median disease-free survival in a PT3N0.
PT3N0. What? 40%?
Okay. No, not 40%. I'm asking months.
Oh, months.
Yeah.
What about 24, 36 months?
Okay. He said 24 to 36 months and you are saying the same. Manikandan, any other number?
I will say it's 18 to 20 months.
18 to 20 months. You are all very optimistic in the world. Okay. Gautam, you have given neoadjuvant chemotherapy.
We do wonderful operations, Sanjay.
Even then, that's why you got an R0 resection. Yeah. So you are given neoadjuvant chemotherapy and done a radical cystectomy. It is YPT2N0. Margins are clear. What is the median DFS?
Okay. It is the same T3 was given neoadjuvant and then it has come in biopsy as YPT2, sir.
YPT2. The pathological specimen says YPT2N0.
Okay. So median DFS would be
same 24 to 36?
36 months, sir.
36 months. Okay. Raghu?
Because there is a downstaging.
Yeah. Raghu? No, it's not the same patient. I'm saying you have done a radical cystoprostatectomy after neoadjuvant and it is YPT2. Rajesh, any change? Oh, you can't. You already know the answer, so you can't answer that question. Yeah. YPT2. What is the median DFS? Manikandan? Same? 24 to 36?
I'll say 48 months.
48 months. God, you're going to live forever. Okay, so these are the questions for 2025. Let's see why we need any more. Okay, so adjuvant immunotherapy, any survival benefit? Raghu, adjuvant immunotherapy, you just covered that.
Yes.
So you have done in both these settings, you say, oh, you need to go for adjuvant immunotherapy. Any survival benefit?
22 months.
You get RFS or
EFS.
Huh?
EFS, that is event-free survival. Or
no,
DFS.
I'm looking for overall survival benefit with immunotherapy. Just with adjuvant immunotherapy.
I'm not able to give a number immediately, but
no. You think there is a benefit, survival benefit?
With adjuvant immunotherapy?
Yes.
In OS?
Yes.
A few percentage, very close to about 3 to 5% advantage than not giving. That's all. It's not going to be phenomenal. None of the papers I read showed any phenomenal results.
So provided immunotherapy was added in the neoadjuvant continuation.
No. Neoadjuvant is just chemotherapy.
Neoadjuvant is zero, nothing. You just did cystectomy and adjuvant.
Cystectomy with a PT3N0. Okay. And then the next one is a post-neoadjuvant, but YPT2. You give adjuvant immunotherapy. What is the survival advantage you quote to your patients?
Maybe very few, 2 to 3%, because most of the immunotherapy that we give is in the metastatic setting.
Yeah.
And the adjuvant immunotherapy, there are only phase 1, phase 2 trials as of now, without any neoadjuvant therapy.
Raghu, whatever you talk, nobody was listening. Okay, so radical cystoprostatectomy, these are the standard ones. So these numbers are right. We say what is the expected 5-year survival for all muscle invasive bladder tumor? 50 to 60%. What is the survival benefit with neoadjuvant? 5%, 5 to 7%. Adjuvant chemotherapy, what is the survival benefit? Around the same, but less robust data. Okay. Now, what is the survival difference between DDMVAC and GEMSIS? This was the Vesper study that Raghavan had already quoted. If you see there, this is almost touching 1. It is 0.5 on confidence interval to 0.96. And this is progression-free probability. But when you look at the overall survival, actually it crosses. If you see the overall survival, all patients, it crosses 1.05, and even this one is reaching. I don't know what's the difference between these two. So overall survival difference is a bit. The progression-free survival is supposed to be better with DDMVAC, but OS is not as strong as what we are made to believe. That's one. And second, the toxicity is a lot more. That's the reason the DDMVAC has never taken over. Would you agree with that, Dr. Vasini?
Yes, sir, because there is not much significant overall survival OS benefit with DDMVAC over GC, but with an added toxicity. The major roadblock for DDMVAC is the toxicities it is associated with, and we cannot complete the entire course of treatment with the prescribed dosages. There is always the need for dose reductions or delays in treatments compared to the GEMSIS protocol.
Okay. So that's the reason, Raghu, people haven't moved on from GC to DDMVAC.
In fact, DDMVAC was an older protocol.
Yes, and then it came back in. Yeah.
Yeah.
Actually, when you see it, GEMSIS doesn't have any evidence in a neoadjuvant setting. It is from the metastatic setting. It hasn't been trialed in an RCT in a neoadjuvant setting. GEMSIS, my understanding. Dr.
Yeah,
Vindhya?
other than the recent trials.
No, no, I don't think there is any evidence for GEMSIS in a neoadjuvant setting. Is there?
It is only in the perioperative setting.
Which perioperative setting?
So, GEMSIS 4 cycles induction, followed by either cystectomy, or if the patient doesn't prefer cystectomy, we go for a concurrent chemoradiation upfront.
So, which is the study?
I don't remember the trial name, sir. I'll get back one. I'll just check it.
Raghu, do you know that? I wasn't aware of that. So
which one, Sanjay?
She mentioned about perioperative GEMSIS.
No, not to my knowledge.
I haven't seen it, so that's the reason.
But
okay.
Happy to learn.
Yeah. That's why when she mentioned it, I was asking. Okay, so adjuvant. Then we come to these three questions. These are staggering numbers. Okay, so post RC T3N0, what is the median DFS? Post neoadjuvant chemotherapy YPT2, what is the median DFS? Okay, the numbers are staggering. Okay, so this is where it was post radical cystectomy nivolumab versus placebo in adjuvant setting. Okay, so placebo is the control arm. Okay, and when you see this, good enough numbers, 350 patients. Sorry, I'll go to the previous one. So this one was 100 radical surgery, evidence of urothelial cancer, high risk of recurrence, and the high risk of recurrence is T3 or YPT2 N0 or NEN. Yeah, Gautam?
Sir.
Yeah, so any T3, YPT2 or any N0 were the inclusion criteria for this. So nivolumab versus placebo. I mainly want you to look at the placebo one. So the placebo one is 10.9 months. So what I mean by that is if somebody has got a T3 N0, 50% of them will recur by 11 months.
Okay.
50%. So YPT2 post neoadjuvant chemotherapy, 50% will recur by 11 months. That is staggeringly short. I always thought it was 24 to 36. Yeah. So this one, it improved the DFS, disease-free survival. The reason why DFS is taken as a good marker for urothelial cancer is, this is death. This is not prostate cancer wherein they might have recurrence, but they won't die. In bladder cancer, if they recur, they will die. Yeah. Raghu, is that a new number for you? 11 months? And
11 months is, yeah.
And this was T3 or YPT2 or NEN. Manikandan, so they don't live for 48 months or they don't have median survival of 48 months. They have median survival of 11 months. That's the reason why we should be.
I told 18-20 months.
Sorry?
I told 18-20.
No. When I asked you YPT2,
Yeah.
Okay. So 24. So still it is half of that. Yeah.
Yeah. Correct.
And this was the pembrolizumab study design phase RCT. This was the, again in the adjuvant setting, if I'm right, post-radical surgery. Yeah. Neoadjuvant chemotherapy or patients were having adjuvant, and it's the same numbers. When you look at 50%, yeah, DFS, both studies, you're looking at around 11 months, 50%. Yeah. So DFS, these patients do have a very short DFS. Median follow-up was 20 months. So 70% recover by 30 months, 29 months versus 14 months. So in a normal setting, post radical cystectomy at T3, DFS is around 11 months to 14 months, and majority, 70% will recover by 30 months. In 2.5 years, 70% will recover. Okay, so this is all about saying that why we need more treatment for this. Okay, so going back to this, post RC T3N0 median recurrence-free survival is 11 months. Post NAC RC YPT2 median recurrence-free survival is 14 months. Adjuvant immunotherapy DFS is better, but there is no OS benefit yet. Okay. So these are the numbers. So that's the reason why we are where we are, which is the Niagara study. Okay. What do you think about the study protocol? Do you think we should be giving patients neoadjuvant as well as adjuvant? I'm going to ask Dr. Vasini. Or do you think they should have just tried this neoadjuvant one, durvalumab plus Gemcis versus Gemcis?
So right now, all the oncology trials, they are concentrating on the perioperative setting, that is giving chemo immuno in the neoadjuvant setting, followed by maintenance immunotherapy for at least an year. This is the various reasons have been cited, starting from taking care of the spillage during surgery and also the microscopic disease that might be there.
But won't that be taken care of by the neoadjuvant one?
So spillage, surgical spillage.
Surgical spillage doesn't happen in a cystectomy.
So those are the points rationalizing the adjuvant immunotherapies in other oncological settings, other sites of tumor. So right now, most of the, especially the chemo immuno trials in majority of the primaries like breast or lung, there is perioperative treatment rather than limiting only to the neoadjuvant therapy.
Okay. Raghu, what do you think? There should have been another arm wherein they just gave durvalumab with Gemcis without
my
adjuvant.
problem with this study is that you are comparing a set of patients who received adjuvant versus patients who didn't receive adjuvant. And that is very, it's a slightly non-comparative problem. If they would have stopped with Gemcis without durvalumab as only a neoadjuvant, I would have been okay with that. Here, you are definitely comparing a set of patients who received more treatment than the other set. And therefore, then comparing and saying that the EFS was better and PCR was better. Well, PCR understandable, but EFS may be influenced by other things as well. So that is a very intriguing point.
The other way I would look at it is the patients who have had neoadjuvant, yes, they are comparing it with the GC, which is the current standard of care for you. Yes, so it's not that they are comparing it with a placebo. So they are only saying that whenever you give immunotherapy, they know, as Dr. Vasini was saying, it is always perioperative immunotherapy. So they know that that is the standard. So they compared it with neoadjuvant followed by adjuvant, and you are not giving Gemcis in a adjuvant setting in a normal way. Do you understand what I'm saying? So one way of looking at this was durvalumab plus Gemcis followed by durvalumab, gemcitabine cisplatin followed by adjuvant Gemcis. But you don't give adjuvant Gemcis. when you have given them a neoadjuvant.
The other, Sanjay?
Yeah.
Is it okay that the trial investigators would have looked at if there's a pathological complete response?
Yeah.
They could have withheld durvalumab in the group of
Super.
those subset of patients. That would have given a meaningful response.
That's the slide that Raghu projected, but he didn't. I looked at it the other way around. Is there any efficacy of adjuvant immunotherapy in patients who have got pathological R0? Yes,
Yeah,
actually
that
there
is the
is.
next thing to
No,
look
no,
at it.
no, it is there. But Raghu looked at it the other way around. So when that was the same question. So I said, you give neoadjuvant, you get a path CR, then stop the immunotherapy. But actually, even in path CRs, when you continue with durvalumab, it seems to add more compared
OS benefit.
to not. Does that make sense? So the pathological complete response one, even in those, you will find that having the adjuvant durvalumab seems to make a difference. These EFS, these points, Gautam, do you think these are good enough?
Progressive disease. Yes, sir. They are seeing the progressive disease after RC, recurrence after RC, date of expected surgery in patients who did not undergo death from any cause.
It was the third one was difficult for me to understand.
Yeah, I couldn't understand.
I'm only thinking that because of the toxicity of the medication, the planned date of surgery could not be done.
Yeah, because of the side effect profile.
Because of the side effect profile. So that's why they had to add it as an event.
Yeah. Or death from any cause. Yes.
Yeah.
I think we are adequate.
Okay. So this was the first question, neoadjuvant versus adjuvant. As Dr. Vasine has said, currently for immunotherapy, it seems to be around. Okay. No systemic versus perioperative. Do you think which is not the current standard? Because as I said, if they wanted maximum benefit, they would have compared durvalumab plus Gemcis versus placebo. But they compared it with what the current SOC is. Yeah. Event-free survival. Now I'm going to ask Dr. Harish Kumar. Yes. These last two.
Yes, sir.
Yeah. How does this fit in with RT in adjuvant setting and peri-RTIO? Are there any trials in that setting?
So RT in adjuvant setting, only if patient goes for direct surgery without any neoadjuvant chemotherapy and they land up in any T3, T4 tumor, margin positive, node positive. So their RT can be added as an adjuvant setting. And peri-RT, right now, I don't think any trial is there, sir. But maybe in future may come.
Do you think it would work better with RT compared to surgery? Because immunogenic reaction is there.
Yes,
and
sir.
by RT, you also say that you increase the immunogenicity of a tumor.
Yes, sir. But selection will be a very difficult in that, sir. Because so you know that radiation in bladder is very, very stringent patient criteria, sir. Like we take only T2, T3A, N0, unifocal, less than 5 centimeter tumor. So that criteria should set in before you choose the patient for radiation. And as you told, the radioimmune are going to help us in tumor regression. So when our patient is chosen for radical chemo with organ preservation, I think only evidence will tell, sir. But as of now, radioimmune response will be better. And I feel personally that if patient tolerates, there will be better response.
Okay, so none of these patients had, a very small percentage of them were N1, yes. And though the creatinine were lower, they were only about 20% of the overall patient cohort were the lower creatinine one. Yeah. So this is the EFS and OS. Yeah. This is what. So what we were looking at was what is the compared. So if we look at 60 months, it is coming to 50%, Raghu. So when we ask the first, this is for the event-free survival, and this one is 60 months. So the overall survival seems to be better in the control arm of the Niagara study at around 65% or 65 to 70% even at 5 years, which is better than what we initially quoted, which is around 50% or 50 to 60%. But generally in trials, they tend to do the control arm is always slightly better compared to what you would expect it to. Like here, gemcitabine cisplatin is 75% 24 months and 60% event free. So there is no recurrence even in 60% of the patients. So that is, the control arm seems to be better in this study compared to what you would expect outside. Raghu, any comment on that? You would be muted if you are trying to talk. Hello?
I'm so sorry. I need
Yeah.
to fiddle around to find my mic button. Yes, Sanjay.
So I was just saying the control arm seems to be better than what you would expect in your day-to-day life.
See, that's what I'm telling. You were saying that the survival is very bad. No? The survival is actually okay. So on an average, 50% with just RC, 59 with GC with RC, and an increase in 67 with the Durva added to it as well.
So 50, 60, 67.
Yeah, something like
So
that.
50 just with radical cystectomy, around 60, 57 actually, but 57 to 60 with neoadjuvant chemotherapy. And this adds another 5 to 7% OS.
Yeah, exactly.
So this is the PATH CR. That's good. And this one, nothing much. Okay. Adjuvant treatment in the PATH CR group. Okay. This is what it was. So if you see there, pathological complete response, they continue to get better with the if it was supposed to be just the gemcitabine cisplatin doing the job, this would have come back together. But there is continues to be separate. So these are all the patients who had pathological complete response compared to the people who did not have pathological complete response. So definitely, yeah.
Sanjay, for a long time, all of us know that any neoadjuvant chemotherapy almost allows you to do a case selection process. Patients who respond well to the neoadjuvant chemotherapy usually do extremely well as well in the post-operative setting. And that's what it reinforces. So those patients who didn't have a very good response have, are almost touching 50% in the best as well, vis-a-vis those who had good responses. Even in the GC arm, look at that. Even in the GC, they are doing extremely well.
No, what I'm saying is patients who have had a pathological complete response, whether it is following GC or GC plus durvalumab, continuing with the adjuvant durvalumab seems to be adding better, because these patients, there isn't any, still the difference seems to be maintained. That's what I'm saying.
I understand. So the next question that came to my mind is, why not just give durvalumab in the post-operative period? Why pre-operative period as well?
So that's the adjuvant one.
Those are questions I couldn't answer myself.
No. That's where the previous one, the reason why I showed you that nivolumab one was, nivolumab only give it in adjuvant setting.
Adjuvant setting. It
And
was
that
all the
did
three
not
trials
work.
were adjuvant only.
Yeah, so that did not work. So what it was showing is adjuvant only improves the DFS, doesn't increase the OS. Okay. Neoadjuvant does it, but not in a proper way. So that's the reason you need perioperative.
Good.
Yeah. Did I make my point?
You did. And very truly so. So now we are moving to peri-adjuvant therapy for all cancers, isn't it?
Yes. For prostate as well, we are doing the same, and this one as well. Manikandan, did that answer the question? Or I didn't know who it was, whether it was Mani?
Yeah. Yes. It's fine.
So did that answer your question about choosing and say, okay, once they get PATH-CR, why don't we stop it? Yeah?
Yeah.
Because what I was thinking, if the GC has achieved PATH-CR, you would think that these both two will merge up and they will be maintained. No, there are still recurrences coming and people are dying, which is better when you give durvalumab.
But we need to be cautious with respect to the quality of life and cost and other issues, which the extra burden which will add to it. That data we have to look at it.
Yeah, 100% is the answer to that. But it is always about first thing, is there a good enough quality data for us to change our mindset? Is the first question. Then we have to say, okay, what is financially viable? And what is financially, when you say, what am I getting for the amount of money that is being spent? So
True.
that's what I was. Yeah.
Yeah, true. Secondly, as Dr. Ravan said in the beginning itself, the selection criteria was younger, fitter patients with a very good risk profile. So all these things, all these patients would have tolerated the sandwich regime very well.
I
So
agree.
the real world data, we need to look at it. Then only we can draw meaningful conclusion. That's my
I
observation.
agree with that. The only other way I would look at it is actually in a higher risk patient, if they were, because there were only 5% of these patients were N1. Yes. So higher risk, wherein there is, you can see that there are lymph nodes. Probably this works even better. You can look at it that way as well, isn't it? With respect to toxicity, yes, you need good performance status. But with respect to the volume of disease, there would be more events if you
But
actually
the
take
numbers are
much higher
smaller.
risk. Sorry?
The numbers are smaller. Numbers are smaller.
No, I'm not saying there is evidence in this study. I'm saying
Yeah.
putting it the other way around and say actually only the lymph node positive patients are the ones probably good enough for this one. So this is what it is. Okay. So this is where when you use them in adjuvant setting, there is no survival benefit. The Checkmate 274, Nivolumab, Ambassador Pembrolizumab, IM Vigor, Atezolizumab, none of them showed OS benefit. So that's the reason for giving it in both perioperative setting. Okay, and this have been covered. Okay, any questions on this one? We'll do probably 15 minutes of the NMIBC. Any question? Gautam, do you have any questions to ask?
No, sir. Nothing.
Okay. Raghu, any final points you want to add?
Now, secondly, we need to look at the this sandwich regime in patients with variant histology as well, because in the forest plot we understand that the variant histology patients were not doing well, maybe comparatively.
It will be the same picture that we have with the renal cell cancer. Yes, it's
Yeah, that
variant
differs.
histology. You never
Yeah,
know what to do with them.
yeah. So we need to have a very good pathology report or pathologist looking at it with IAC markers and other thing. That's also plays a key role in our real world setting.
One,
Yeah,
one,
yeah.
sir, please continue. One
Sorry, go
question
ahead.
I wanted to ask is, sir, when the MABC is diagnosed, any molecular markers are, we know the data of FGFR mutations, which are definitive can be used, and other things like PDL1, even for durvalumab. Any suggestions to do any markers?
Currently, there isn't, is the answer.
Yeah.
We were trying to do that luminal and those sort of ones. Still, the tests don't come up that easily.
Okay.
The IHCs, we were just using the IHCs. They are not as easy as what the literature would suggest. The last thing is when Ashish Kamath was there last time. I said, why are people not using the luminal and those substratification of NMIBC? He said, it hasn't yet been validated in clinical setting. It is still in research setting only.
Mm-hmm.
And that is all the publications from that one have come from Ashish Kamath. And he says, don't use it yet.
Okay. And what about PDL1 positivity, sir? When we are planning to give durvalumab
There isn't
perioperatively?
any. Again, the way I read it and Raghavan was saying, PDL1 doesn't seem to make any difference.
Okay.
Yes. You can tell them probably it might work better, but it doesn't seem to change it. Then I find it strange in that it is a PDL1 receptor antagonist, but it doesn't matter whether the patient has got PDL1 expression or not. So there might be other immunogenic pathways that it is working on that we are not yet aware of.
Okay, sir.
Yeah. Dr. Vindhya, can you answer that question? Why
So
is
actually,
PDL1 not making any difference?
PDL1 is actually not a good marker for immunotherapy now, right now, even in colon cancers and other cancers.
No, sorry, that wasn't the question. I was saying you are using a PDL1 inhibitor. Yes. And then still saying that, okay, it doesn't matter whether it is expressing PDL1 or not.
So in bladder cancer, there are it is a hypermutated. There are neoantigens that are present in the tumor microenvironment, which increases the immunogenicity of the tumor itself. So irrespective of the level of expression of PD1 or PDL1, these immunotherapy drugs, they can stimulate the tumor infiltrating lymphocytes to act against the tumor.
Okay. So it doesn't need to be dependent on. Okay. Thank you very much. We'll move on to the NMIBC. I will make it short. I'll make it 15 minutes. I will thank Dr. Harish Kumar, Dr. Vindhyavasini, Gautam Krishna, and R. Manikandan. Yes?
Thank you.
Thank you, sir.
Raghavan, just hang around for about 15 minutes. Okay. And I'm going to request Srivatsan. Srivatsa, are you there?
Yes, sir.
Srivatsan. Okay. And Dr. Niranjan, medical oncologist.
Apologies, sir. Dr. Niranjan sir is not due to some emergency. He couldn't able to join.
Would it be possible for Dr. Vindhyavasini please be around? Hello. Okay. Dr. Harish Kumar is there. Srinivas, G. Srinivas.
Hello, sir.
Hello, sir. You are around. Madhav.
Hi, sir. Good evening.
Okay. Thank you all. Thanks for joining in. I have, okay, again, this one, the slides have been provided by AZ, but I've modified them. Okay. This is, I'm just going to ask a generic question. Rajesh, you started off with this one and I started off with this one as well. Bladder cancer, 70% of the cases in US are NMIBC diagnosis. What percentage of in AINU? It's a selected cohort that come to you. And next I'm going to ask Dr. Srinivas because he works in a more generic setting than us. What percentage of bladder tumors are NMIBC? Sorry, you're muted.
More than 80% in our setup, sir.
NMIBC.
NMIBC. More than 80%.
Okay. G. Srinivas?
I would say around 50 to 60% in our setups.
Okay. And it's 70 to 80%, you said, Rajesh.
More than 80%, sir. More than 80 in our setup.
Out of that, how many of them are high risk?
The high risk is around 50% of them.
Okay.
50%.
Srivatsa, what do you see? So when you look at when you tell there are new 100 bladder cancers that are picked up, can you give me numbers for metastatic, muscle invasive, high risk NMIBC and low risk NMIBC? Just what you think are the numbers. Okay. Don't in India, don't quote me literature. And there isn't any literature for India. So that's why I'm asking, what do you see in your practice?
In my practice, if you see, I see about 10 to 15% of metastatic outright. Being a referral center, I see more of, I would say, equal proportion of muscle invasive and non-muscle invasive. Because most of them already get a TRBT and re-TRBT and then referred for this thing. So I get a equal mixture of, I would say, equivalent non-muscle and muscle invasive.
How many of them are low risk?
Low risk are almost quite a bit of number of low risk. I would say 30 to 40, because when I started my practice, it was mostly high risk. But now, having been in 5 to 7 years, I think it's 30-40% is low risk.
Okay.
It's actually more confusing than high risk, according to me.
Okay. Again, each of us have different practices. I don't get any low risk cancers at all. There are only high risk cancers. Thankfully, now the metastatic rate has come down, but all these numbers depends on where you practice. The reason for asking G. Srinivas is he is a bit more closer to the community than any one of us are. So that's the reason for asking. Dr. Srinivas, do you agree with what the numbers that Dr. Srivatsan quoted? If there are 100 new cancers diagnosed in India?
Yeah, we do see quite a good number of muscle invasive ones, sir, at our setup. We hardly get to see 50 to 60% of NMIBC.
Okay. 50 to 60%. Okay. And I'm going to ask Raghavan, who has lived a bit longer than all of us. Do you think we need a new medication instead of BCG, Raghu?
100%.
Huh? Why?
100%.
It's a brilliant drug.
It's
Has
a
been there
brilliant
before you
medicine.
existed. Sorry?
It's a brilliant medicine which leaves the patient miserable and the doctor not knowing what to do.
Okay, but it works. So we are
Yeah.
going to add
Okay, you
immunotherapy to
can see
BCG.
for us to chase away the cockroach, you can burn the house as well.
Hmm. So you know that it works, but you're just worried about the side effect profile.
It's
Yeah?
miserable, Sanjay. It's
Okay.
miserable, especially if you follow the Donald Lamb protocol of 6 plus 3 plus 3. By the time they finish 6 plus 3 plus 3, they are dead.
Hmm.
They're dead, genuinely dead. I do not know what to do with them. Or I'm seeing them in that way in Chennai, and you guys are having nice time in Delhi and Bombay and other places, or in Hyderabad. But
Hyderabad
Chennai
water is
patients
good.
are not able to tolerate at all.
Hyderabad water is good.
Ah,
Rajesh
I know.
Banjara Hills, except for Banjara Hills.
Yeah.
Okay.
Hey, just answering the question which was discussed a minute ago. See, we looked at a 500 patient audit of TRBTs done in Apollo Main, which is a general hospital, not a specialist hospital. And what we realized, 500 consecutive patients who had TRBT, 40% were high-risk disease.
40% were high risk.
Yes.
High risk means NMIBC or muscle invasive?
G3 plus.
Okay. No, that's again G3 plus NMIBC or G3 plus MIBC as well.
Okay. You continue with the discussion. Give me 2 minutes time. I'll pull that data set and tell you in the next few minutes time.
Fine. So this question I keep asking, Srivatsa. A patient comes to you, you have done a TURBT, it's a 2 centimeter tumor, G3TA. Is it low risk, intermediate risk, or high risk?
G3?
Single lesion. G3TA.
I would say anything G3, I would put it in the high risk, even though it's TA.
Okay. Rajesh, where would you put it?
So I put it in high risk only, sir.
Okay.
But recently, as per the EAU, it comes under intermediate now.
No, it has always been in intermediate. We never saw it.
No, sir. In previous EAU guidelines, it is high risk only. Any high grade, it is G3, it is in high risk.
No. At least for the last 2 years, when I have noticed it, we were not looking at it. We were always looking at the definition, which is whatever doesn't fall in the low risk and high risk is the intermediate risk. Okay. So when you look at here, solitary low grade TA 3 centimeters, multifocal low grade, then high grade TA less than 3 centimeters is intermediate risk.
This is AUA, sir. AUA and not even.
No, EAU also has it.
Where, sir?
Huh?
EAU doesn't have. EAU high grade is always high risk disease.
No. I didn't put this one, but EA G3. Okay, let's look at this one. So G3 T1 with or CIS present, grade 2 TA, all this. So there is no G3 TA, just G3 TA. Youngish patient, male patient, G3 TA, single less than 3 centimeters, it comes under intermediate risk. Trust me. I said this to you before as well, but you didn't check it. I've checked it.
Oh, okay,
Yes?
sir. Okay.
Okay. So that's why whenever you see anything being mentioned as intermediate risk bladder cancer, actually they are talking of, there is a randomized control trial of mitomycin versus BCG. I thought, God, these people are giving BCG for intermediate risk, which are low grade. My understanding was low grade recurrent multifocal are intermediate risk.
So whatever you are telling, it is based on AUA classification, sir. But EAU doesn't have, as far as I remember.
I'll share it in the group, or I'll share it to you later.
Yeah, please, sir.
Yeah, the blue table has it.
Maybe recent EAU considered
No,
high grade.
for the last 2 years.
It's changed in the last 2 years.
Last 2 years, I'm telling
last
the
2
previous
years.
one.
No, 2 years is old enough. It's not. It's not 2026. For the last 2 years, it has been there. Yes.
Okay, sir. Okay,
So that's why whenever you see intermediate risk, actually see the components in it and say, actually, who are these patients who have what proportion of patients are there, whether they are low grade multifocal or not. Okay.
Sanjay, just one point which I said. So this is burst data, BURST, for the thing we collected. Pundlep or very low papillary urothelial malignancy of unknown potential 14%. Then low grade, as in LG, is 46.8, HG is 34.5, and none of the terms mentioned is 4%. So we are having a much higher proportion of high grade cancer compared to what is published in the literature.
Yes. So we
And this
get
is from a
40,
general hospital.
Yeah, 40% high risk, is it?
Yeah, roughly yes. Roughly yes.
Okay. And this one you are saying NMIBC? Or
No,
you
high
didn't
risk includes TA, T1, T2,
all of them.
It's
Okay,
a high grade,
40%,
HG.
40%. Okay. Yeah. So the reason why I was saying is, if you look at the NMIBC risk strategies, G3TA falls under the intermediate risk, but you treat it as a high risk. Yes. That's the reason wherein you just don't just go with the intermediate risk and then start giving mitomycin. Mitomycin won't do anything for high grade TA. So again, I asked this question to Ashish Kamath when I said specifically those under 70-year-old, single lesion, less than 3 centimeters, high grade TA. It is intermediate, but you treat it almost like a high risk. Okay. What part of the BCG works, what part of BCG doesn't work, i.e. which part does it prevent recurrences or does it prevent progression? Raghu, which one does it do well? Does it do both well? No, he doesn't want to answer because he is muted and he can't find his okay, Srivatsan, which one does it work and which one doesn't work?
Yes, both well, sir. BCG.
It works both of them. Okay. Rarely have I seen progression with BCG. The initial one would be they might recover, but almost if they had progression, I feel that we have missed it.
After the completion of the induction, maybe 6 months later or something.
No, what I meant is when you do it at 3 months and you see that there is T2, I feel that you missed a T2 at the beginning.
Yeah, agree.
Madhav Tiwari, the nicer version of Raghavan, what do you think? Which one does it work?
I also think a bit of both, but I also think where it is not working is maybe those patients who we have missed CIS or some variant histology.
Okay. Again, I'm going to, how often have you seen just CIS in Indian patients, Madhav?
I would say
Only CIS. Huh?
Less than 10%.
I've never seen it. In the last 9 years, I've never seen just CIS in the bladder. You would always have peritumoral, but in UK, you used to have this entity called just CIS, the whole of the bladder. But I haven't seen. Rajesh,
Sanjay, once again, the audit says 3% are CIS, only 3.
No, that is only CIS or
no, it is G3 with CIS.
Okay, that's what I'm saying.
Situ alongside other problem.
So it's
isolated CIS and not seen.
I have not seen
concurrent CIS, it's called.
No, recurrent CIS with high grade TA.
Yeah. Anything, sir.
Usually, yeah, concurrent CIS, that is G3 with CIS, not isolated CIS that we have seen in UK. No.
Okay, so this one multifocal high-grade T1 non-CIS patient, currently having heard Rajesh Adapalla talk for 25 minutes about his Potomac study. Madhav, which one would you offer him?
BCG alone.
BCG alone. Srinivas Garu, which one would you offer him?
I would go with early RC, sir.
Early RC, because it's multifocal high grade.
Yes, sir.
Okay. How old? 62-year-old. No autoimmune disease. Okay, fine. Rajesh, what would you offer him?
Sir, obviously, I'll give 2 options, sir, B and C.
B and C. Okay,
Yes,
because, okay. Srivatsan, have you had any patients wherein you have offered IO plus BCG?
IO plus BCG in non-muscle invasive, no, sir.
Okay. So you're not yet convinced with what Dr. Rajesh has said. So these are all the studies. Currently, the 2 that are there is Potomac and CREST. Both of them are published. Okay. The CREST one has already been covered and Potomac has already been covered. I just wanted to, when I read the methods, Raghu, I wanted to know in your practice. So what these patients, they had 6 weeks of BCG. Yes. The dosage of BCG is equivalent to 40 milligrams, not even 80 milligrams. Yes. If you look at colony forming units. But when they checked it at 4 weeks after the induction, if there was persistent tumor, they again gave 6 weeks more of BCG.
That is for carcinoma in situ.
Yes. No, any persistent disease, they said. Overall, CIS was very small in that.
Persistent carcinoma in situ, they have done a reinduction.
But what do you mean by reinduction in a generic sense?
Again, they started giving.
I know, but what is the time period between your first induction and reinduction? Generally,
Probably after 3 months they got, and again reinduction.
No, I'm not talking about the study. Generally, when do you reinduce?
So probably the persistent recurrent high.
I'm saying time period.
Time period.
My understanding was that the BCG is working, and then about 15, 18 months down the line has got a high grade NMIBC. Then you say, oh, let's reinduce because BCG has done the job. But to give 6 and then go back again for 6, that is not reinduction.
That is only for carcinoma in situ, sir.
No, I understand. Even if you have CIS, to give again another 6, there won't be any patient alive there. Have you ever done that, Srivatsa?
No.
I was surprised to see that they gave, and they didn't give what proportion of the patients had that, but they just said patients who had residual disease after 6 weeks of induction had again reinduction. Yeah. And the second thing, sorry? Sorry?
Who does a 6-week cystoscopy? I mean, I believe maybe they started late, 4 weeks after the TRBT. I mean, my first cystoscopy is at 3 months.
Okay. Depends on when do you start your date. Yes, the date is from the first date of BCG. So normally what you do is you give 6 weeks of BCG and then you wait for a month and then do it. So it's almost 2.5 months.
Yeah, almost 3 months.
So you never do anything less than 1 month after a BCG.
By reinduction, do the main CIS, sir, or for CIS or a residual disease?
So Rajesh would have read it better. When I read it, I thought CIS or any residual disease. Rajesh, was it only for CIS?
It is only for CIS they've reintroduced. I mean,
but before
not considered.
But before instilling BCG, we are supposed to do a relook TURBT and resect all the tissue. And
So no. So what has happened is all these patients have had a complete TURBT. Then they had 6 weeks of BCG, waited for a month to do the rigid cystoscopy. And when they had the biopsy done, when it showed, as in Rajesh says CIS, they had another 6 weeks of it. So that's what is the scheme of things.
So did they discuss, I mean, did they give in this their chart whether they were looking at a CIS or a residual T1
CIS, as I said, I read it as residual disease stroke CIS, but Rajesh has read it better and he says only when there is CIS and it's there in the method. So they did not, it was there in the initial method section. So that's what they were planning to do as well.
It's as if somehow they expected the persistence to be there.
Yes. And this potamab, the crest, the sasanlimab, just a minute, Umesh is calling. Go ahead, Umesh. Yeah. Okay, fine. Okay, thank you. So I'm Dr. Neelakandan has joined. Sorry, when I took the attendance at the beginning, he wasn't there. So that's the reason I didn't ask them. Sorry, Neelakandan. I wasn't aware that you were there. That's the reason. So when I initially called out, you were not there. That's the reason I didn't. Okay. If both of them are available and cost efficient, Rajesh, would you use the sasanlimab or durvalumab?
Sir, based on the one thing, sir, there is only one difference between the durvalumab.
No, subcutaneous and IV.
Even carcinoma in situ, sasanlimab worked better, sir.
So we don't have carcinoma in situ.
But that is again, there is no head-to-head comparison.
No, you don't have carcinoma in situ in India.
We have, sir. We do have.
No, we just showed you the numbers. Pure CIS.
How is it
Pure CIS? No, I'm telling it associated. Concurrent. Concurrent.
Concurrent, yes.
Concurrent carcinoma in situ, if along with the high-grade tumor, there is a concurrent carcinoma in situ, probably sesanlimab works better.
Okay.
But,
For
based
me,
on the preliminary data we have.
Yeah.
Otherwise, the overall, durvalumab is doing a great job, sir.
Okay.
Because it's only for 1 year, and we have a 5 years this one median follow-up.
Yeah.
Whereas for CREST, it is only 3 years.
3 years. The only reason why I was asking is it is subcutaneous. So it's almost like we are used to giving subcutaneous injections compared to intravenous.
Yes.
But the toxicity is almost same, if not worse, compared to durvalumab.
Probably toxicity, immunotherapy related toxicity is more with
sesanlimab.
Probably because we are giving for 2 years.
Yes. I don't know why they gave it for 2 years, but anyway, that's where we are. So you are your favorite one. For BCG failures, Raghu, where if you have 100 BCG failures, what percent, and they're all fit, they can all afford. Okay. Now the question is, do you think you can try BCG with durvalumab? Rajesh?
But we don't have data on
Yes.
BCG.
So these are all BCG naive.
Sir, the BCG unresponsive setting, we have data on pembrolizumab. We have data on other medications like cretostigmazine and astiladrin, all these things. But there was a presentation in ASCO 2025. So-called all FDA approved drugs versus gemcitabine and docetaxel. So, when compared with all the other medications, all fancy medications, gemcitabine and docetaxel fared well in BCG unresponsive disease.
Okay.
But
So
again, it is a network meta-analysis kind. It is not a head-to-head comparison.
I'm going to ask this question to Neelakandan. So if there are 100 patients whom you have given BCG and they have failed, I'm not saying 100% of them fail, what percentage of them, 70, a typical 70-year-old fit enough guy, what percentage of them you would counsel towards going for cystectomy? What percentage you would say, let's give gemcitabine docetaxel a try? Neelakandan? Madhav, I'm going to ask you the same question.
I would not counsel many to go for gemcitabine.
Okay, because you don't believe it works in that setting, or you
not
think
in the BCG unresponsive setting. If it is BCG unresponsive setting, I think maybe IO plus BCG may be better.
But there is no evidence, isn't it? It's only in BCG naive patients, IO plus BCG might work, not in BCG failure patients, because BCG failure, there are other studies which have used it and it's not that very effective. I'm just going to, Neelakandan, you don't want to talk to me? Still. So, huh? I can't see him. Are you there? No, he doesn't want to talk. Okay, Rajesh, go ahead.
So I have a small submission, sir. The question was different last time what you asked. When we compared with the other available regimens, gemcitabine and docetaxel, but not when compared with the radical cystectomy in BCG unresponsive disease. Whatever the bladder preserving therapy so far we have, it is inferior when compared with the radical cystectomy in BCG unresponsive setting. I just want to have a submission.
I absolutely agree, sir. That's why, at least in the Indian setting, also considering the costs and everything, I think early cystectomy would be the gold standard for this patient.
Okay. So what I was surprised was they had these 3 arms, BCG, induction only, because the main worry, what we started off, Raghavan is not worried about the efficacy of it. He's worried about the toxicity of it. Yeah. And the toxicity is not, because I thought at least if the induction said, oh, it works as good as the induction and maintenance, then we would have said, okay, IO plus induction is our standard of care from tomorrow. No. When they gave the patients induction, the induction didn't work at all. So induction and maintenance of BCG is necessary. Yes. So actually still the king in this one seems to be the BCG, and this is potentiating it.
BCG maintenance.
And then my worry in that setting is we have already got toxicity of BCG and then we are adding toxicity of immunotherapy. Raghavan?
So actually, they've reported quite a bit of grade 3, grade 4 toxicity
Yes.
with that's very high.
Yes. So the grade 3, grade 4, grade 3 is almost 70 to 80% when we were looking at the perioperative one. Yes. But it does seem to make a difference. So when you look at the recurrence disease-free survival, the durvalumab plus BCG is better compared to just BCG.
So, Sanjay sir, just one question. I'm sorry, I'm tipping it. Is it correct to say that if you look at maybe say 2 years alive without high risk recurrence, the difference between Durva plus versus only BCG is 5%, 7%?
Yes, 5%. And that 5% seems to be all
So,
along.
so this is the same discussion that we are going to have what we had with neoadjuvant in MIBC. The discussion that, oh, it's only giving 5% extra benefit.
Yes. So the way I was looking at it is, as in any study, if you just look at just the BCG, okay, just the BCG, 77% of them are recurrence-free survival at 3 years, which is better than what we quote them. Almost 80% of so the response rate of just BCG is 80%. You're getting an additional 5%, but just BCG seems to be doing the job. And Rajesh, wherever we look at GemDosi, the numbers are around 50, 60. Agree?
Sir, we don't have much data on BCG naive settings, sir.
Yeah, no.
With the bridge
That's
trial,
one. Wherever the settings have been done, the main issue in that one was they were not biopsy counter checked as well. GemDosi one, the biopsy counter checking was not done in them. Yeah. So I was surprised that 80% response rate at 3 years.
So we should look the hazard ratio rather than this one, sir. This direct comparisons like this.
Okay, 5%. So hazard ratio.
Probably here you can see in above the 98 patients had at the end of 5 years, 98 versus 67. And hazard ratio is 0.68. That means there is a 32% disease-free survival risk reduction, rather than just differentiating 82% versus 77%. That is not the actual risk reduction.
No, I understand.
Relative risk reduction is different.
No, I understand the way you are looking at it, but when you tell the patient, you say 30% decrease, or you say there is a 5% additional benefit.
I would say 30% reduction. That is a relative reduction. That's a,
no, if somebody tells you 30% risk reduction, from what?
From the baseline, that is 1. Hazard ratio when compared with the 1, it is 0.68. That is 32% risk reduction.
Yes, I understand. That makes a good one for us to talk about. But when you tell the patient, that's the reason I started off saying that what is the additional benefit you get by relative is almost 10%, but actually is around 5%, isn't it? Neoadjuvant chemotherapy.
Probably it is absolute DFS benefit.
Yeah, absolute DFS.
So maybe absolute means that is that has a weightage.
So for when I read this paper, the biggest thing take home for me was, I think 40 milligrams of BCG is good enough, and you get the colony forming units that will decrease our toxicity. And all these people only had 40, because when they said TICE was only given in 30% of the patients. And all the other people either had Danish or Moscow. Currently, Moscow is the commonest one that is available, that is a bit more available.
So probably, sir. And on top of that, in our Onco BCG, so 1 to 19 into 10 to the power of 8 is the colony forming units in one vial.
Yeah.
But there it is 1 to 8 into 10 to the power of 8.
Yeah.
So in fact, the colony forming units are way less.
In what?
In TICE.
Yeah, TICE it is less. You always have a range for colony forming units. You never have an absolute
1 to 8 into 10 to the power of 8, sir.
So ours is 1 to 18 into 10 to the power of 8.
Ours is 1 to 19 into 10 to the power of 8.
10 to the power of 8. So
yes,
it covers 40 milligrams covers.
Yes.
Yes. So we just got into this idea of giving 120, 40 covers it.
Yes.
Yeah.
Yes, sir.
So again, this last question was Indian patients on MOS when integrating Dura, do you start at 120 or 80 or 40? Raghu, a rich patient comes, lots of rich patients in Chennai are there. He says, I want the standard of care. As of now, I had a patient last week who said, I want to have a standard of care for my bladder cancer NMIBC. Would you offer him this at a 40 milligram BCG? You can't, you might be talking, I can't hear you. So in ideal setting, Rajesh, would you change your practice and the patient can afford it? Would you give him this?
Definitely, sir.
What dosage of BCG?
40.
Srivatsa?
1 vial.
If patient can afford it, do you think the data is convincing enough for you to say, yeah, are they practice changing? At least they will change our perception of how we are treating. That's one. Second, these are our day-to-day practices. Both radical cystectomy and high-grade NMIBC are our bread and butter with respect to urothelial cancers. So if we are going to get a 5% benefit, 7% benefit, or whatever the benefit, we do need to offer the patient. Currently the financial toxicity is there, but I would leave that decision to the patient. Yes. The second, whether the side effect profile will be more because we are using a new durvalumab, I think we will only know it once we start using it in our patient cohort. And then when we use it, then we will know whether the benefit that we are getting is worth taking the risk with respect to the side effects. I have to thank Srivatsan, Harish Kumar has left, Srinivas Garu, Madhav Tiwari, Raghavan, and Rajesh. Thank you all. Good night.
Yes, sir. Good night, sir. Thank you.
Right.
Good night. Bye-bye.
Bye.
Bye.